All right, we're going to go ahead and get started. I just want to ask, how many of you have a strong opinion about direct-to-consumer advertising? And it's okay to say if you don't. So you do. Dr. Griffin does. Anybody else have I am hopeful that at the end of this talk you will have a strong opinion about it. I know a lot of the drugs I'm going to be talking about are oncologic drugs because it really does affect oncology patients a lot, but it affects all of your patients. And please understand that this talk is prompted by, I've known I didn't like direct-to-consumer advertising for a long time, but I wanted to make an ethical basis for my dislike, and I think I've achieved that. And so that's why this is going to be really looking at the ethics of direct-to-consumer advertising, because you're going to have to make some decisions if you go out into practice, how you're going to advertise your practice and how you're going to work with pharmaceutical companies. I have no conflicts of interest except, and this is true, other than the fact that I'm a father who was once asked by his young daughter, "Daddy, what's a 4-hour erection?" We were watching TV, and they talked about if you have an erection lasting more than 4 hours, call your doctor. And she looks at me and goes, "Daddy, what's a 4-hour erection?" You know, I don't want to have to answer that question. And so it's like, how dare them come into my living room, prime time, and talk about that. So we're going to talk about the anticipated goals and unintended consequences of direct-to-consumer advertising. We'll describe why we're in the situation we're in is because there are two different regulatory agencies and lots of places where advertising can fall through the cracks. And as I mentioned, we're going to discuss the ethical implications of direct-to-consumer advertising. If you look at 2012, $27 billion were spent by Big Pharma on marketing of their drugs. And you'll notice that a good 10% of it was essentially on direct-to-consumer advertising. That's not talking to doctors. That's not doing research, that's talking to patients. Now, who benefits from direct-to-consumer advertising? If you think it's the doctor, then you should read this cartoon. So I think we can agree that the doctor shouldn't be the one benefiting. And what about the patient? Well, I would suggest to you that do patients really want doctors who depend upon the patient's suggestion for therapeutic tests and for medications? How confident would you be with your doctor if you said, "Doctor, do you think I should have this test?" And the doctor goes, "Yeah, I think that's a good idea." And "Doctor, should I be on this medicine?" "Yeah, I hadn't thought of that. That would be good." I'd get a new doctor in a heartbeat. You know, I shouldn't have to make suggestions. So who, if the doctor and the patient are not the ones benefiting, who is? I think we know. It's Big Pharma that's benefiting. Now, if you want to know why we're in the jam we're in, if you were able to watch, and this is for us older doctors, if you were able to watch television with your children without having to explain erectile dysfunction and feminine odor and feminine freshness, then the likelihood is that your kids stopped watching television with you by 1997, because all of this started in 1997. And how did we get here? When the original Code of Ethics, the AMA decided that it should ban healthcare advertising to patients, saying that it is derogatory and it was below the dignity of our profession. But it was kind of like Citizens United has been recently with changing election laws. In 1980, a court got involved and said you can't interfere with marketing. So they ordered the AMA to cease and desist from enforcing restraints on advertising. And they said that that violates the Federal Trade Commission Act. So the pharmaceutical companies were now, in the 1980s, allowed to expand their direct-to-consumer advertising to magazines, newspaper, and other media outlets. The standards, though, for advertising to the patient at that time, in the 1980s, were identical to the standards that the FDA had given them for direct-to-physician advertising. They had to use the same rules. And they call that the brief summary, but it's not brief at all. to get away, the FDA said initially, if you're going to advertise to the patient, you have to advertise the same way you do to doctors, and you have to provide a brief summary. And as I said, it's not brief. You have to list all serious risks, less serious but most common adverse reactions, all contraindications, all warnings and major precautions, and the 3 to 5 most common non-serious adverse reactions, which might affect the patient's quality of life or their ability to comply with that medication. Now, this requirement for the brief summary limited the propagation of direct-to-consumer advertising because they could only get away with this really with printed advertisements. And that's why still when you pick up Time magazine and they have an ad, you'll see a lot of this information. The print advertisements were able to provide all that information, but think of trying to get all that information of the brief summary into a 30-second to 1-minute ad. The pharmaceutical companies knew that by providing the brief summary, it would negate any promotional benefits from their advertisements. So guess what? They went back to the courts and they lobbied. And the pharmaceutical companies' lobbies said, we want to get rid of this brief summary, and we only want to provide a mechanism to ensure that the patient can find the information if they want it. So it was changed from the brief summary to the adequate provision requirement, and the courts agreed it would be enough for the advertiser just to include information about the major risks and most common side effects with either a toll-free number, a web page, or a comment that you've all become very used to is, ask your doctor if this drug would be good for you. So that's now all they have to do. So now they can put everything they want into a 30-second ad on television. So the door to near unbridled direct-to-consumer advertising was opened in 1997, and that's when all of these ads started hitting the airwaves. So if we look at what happened in that 10 years from 1997 to this was published in 2006, 9 years, in the past decade, drug companies quadrupled expenditures on ads aimed at consumers. So you can see that they went from 1997, $1 billion when it first started to $4 billion in just 4 years. It's a 300% increase. During that time, they only increased their advertising to physicians by 86%, and they only put money into research and development. They only doubled that. Now, these numbers, keep in mind this is in 2005, before all the Sunshine Acts. This is when you could go to national meetings and walk away with little battery-operated mice, wireless mice, and they gave you everything in the world if you stopped by, not just pens. I mean, they were giving you nice things. So my suspicion is that this number is even lower now because they don't have a lot they can do in terms of giving you things. So what's the result? In one study in 2001, kind of 4 years after this started, they looked at Atlanta at the major 3 networks. They didn't even look at the cable networks. And they found roughly 1,300 advertisements for medications. And 8% of those were related to medications or health care. And I suspect it's higher now. Maybe I'm biased, maybe it's because my eyes are open, but it seems when I'm watching television, there's more than just 8% of ads related to health care. Now, they did a calculation based on this 8% of commercial airtime and said that the average television watcher is watching television 2-3 hours a night was likely to be exposed to more than 30 hours of direct-to-consumer advertising each year. That's 1,800 minutes, and they figure if the average doctor visit is 15 to 20 minutes, they said 100 minutes of direct-to-consumer advertising for each minute that the patient actually spent with a physician. So guess where patients are getting all their information? Not from their doctors, but from advertising. Now, when we talk about the ethical perspective, Big Pharma, they argue that direct-to-consumer advertising is useful. They're doing a public service. We're not trying to get more money for ourselves. We're providing a public service to the community. We're telling people how to recognize diseases. You know, maybe that rash is something you may need to see your doctor about. What you need to be screened for and what your therapeutic options are, as if your doctor can't explain those things to you. The critics argue that direct-to-consumer advertising is really intended to induce condition branding, and we're going to talk about that. That's something most people don't know much about, but it's a big issue in marketing, and so we'll talk about that in a few slides. It's going to contribute to unrealistic expectations of benefit. It's going to play on emotions. It's going to drive inappropriate demands for tests and treatments. We've all had patients come in and say, "Doctor, shouldn't I have a CA-125 drawn? I don't want to get ovarian cancer when I'm older." And result in rapidly escalating healthcare costs. Now, these concerns can become heightened when a life-threatening disorder such as cancer is the focus of direct-to-consumer advertising, and it's not surprising that many of the ads have to do with Cancer Centers of America, MD Anderson, Siteman Cancer Center. A lot of them have to do with Opdivo, the drug that promises improved survival, because these claims tend to be emotionally charged. They provide incomplete information. The Opdivo one says, ask your doctor if Opdivo is right for you for a longer survival. Do they tell you it's 4 or 5 weeks survival benefit at the cost of, with this drug, over $100,000? It's going to lead to overestimation of prognosis and chance of cure. I'll show you a slide later that shows that even at Dana-Farber, the majority of patients think that they're getting drugs with curative intent, even though the doctor says, no, this is palliative, it will not cure them, but the patients don't know that. And obviously it's going to lead to more aggressive care near the end of life because patients can always wait for that next bullet. Now this condition branding, and this is, I was able to track this down. Actually, I had to go to the Shreveport Library, Medical Marketing and Media, where they talk about how to market your drug. And it says here, healthcare marketers are taking the concept of branding a condition to new levels of sophistication. They talk about so some of the things I'm going to mention, like Listerine, is mentioned here, the value of branding. And it says if done appropriately, condition branding has lots of benefits to the pharmaceutical company. So this is what the big pharma reads, how to get you to buy the drug. Now, what is condition branding? Condition branding is when you want to align a product that you have with a disorder that may or may not exist so that they're linked. So once the patient hears that they might have this, they want that drug. And there's 3 principal strategies. The first was to elevate the importance of an existing condition. And this was done with an over-the-counter mouthwash in the 1920s. When Listerine was first, when it came out, in the year 1920, the sales were about $115,000 a year. By them getting smart and calling it treats halitosis, not bad breath. They now gave it a medical sounding name, halitosis. And they said in their commercials that maybe the reason you're not getting promoted in your job, or maybe the reason the love interest of your life isn't interested in you, is because you have halitosis. In 1 year, they went from $115,000 to $8 million because they elevated the importance of bad breath. And most of the people who bought it didn't even have bad breath. They just were afraid they might. Because let's face it, I didn't get promoted this year, and the girl that I love isn't interested in me. So it must be that I have halitosis. This next one is really interesting, and that's to redefine an existing condition and stigmatize you for it. And what's the stigma? Okay, Monistat Stay Fresh for feminine odor. These commercials are still airing, and it says, every woman has a unique scent that fluctuates during her menstrual cycle. We feel embarrassed to admit that it happens to us, but the truth is that it is completely normal. So imagine being a junior high or high school or college female, and because you're seeing these commercials, you walk into a room and you are going to expect people around to be going, who just walked in? Okay? And to be honest, if you can detect the scent and know where a woman is in her menstrual cycle by smell, you're pretty damn close and personal, or you should be getting slapped in the face. Okay? That is not something that we worry about, but they sell tons of this stuff because they've made women convinced that they stink when they go through their menstrual cycle. So that made an existing situation, menses, into a stigma. And then they can develop a new condition to build recognition for an unmet market need. Let's look at fluoxetine, Prozac. Now, they could have just said that Prozac also helps with the dysphoria that some women have with their menstrual cycle, but they wanted to give it a new name. Okay, so they call it Serafem, and the fem is for feminine, I guess. So they took the same drug, same dose, and they call it's being used for premenstrual dysphoric disorder. Instead of use the Prozac that you already have available for mood swings during your menses, let's give it a new name and give it a new, and give the drug a new name, and we'll sell more of the drug. These are the three hallmarks of condition branding. And pharmaceutical companies do this all the time. So condition branders use information about medical conditions to forge links between disease and treatment in the minds of both patients and doctors. That is their goal. These are quotes from the Washington Post opinions. So this is lay people saying this is outrageous. Striking fear serves pharmaceutical companies which want you to worry about diseases, because people who are worried are more likely to go to the doctor and ask for drugs. And it turns out that much of what we think we know about many health problems has been shaped by the drug makers and their marketers. And we've already shown that they spend much more time with pharmaceutical advertisements than they do talking to their doctor.
I'm ready to fight my cancer.
I'm ready to begin chemotherapy.
I really am ready, because I'm going to take Neulasta right from the start to help protect me from infection.
Chemotherapy can reduce your white blood cell count and increase your risk of infection, which could put your treatment on hold. But Neulasta is a white blood cell booster that can help restore your white blood cell count to reduce your risk of infection. And with a sufficient white blood cell count, your doctor may have a better chance of giving you your chemo on schedule, which doctors agree is the first step to success. Neulasta is for most cancer patients receiving strong chemotherapy. In rare cases, splenic rupture or serious allergic reactions have been reported. Report abdominal or shoulder pain or any allergic reaction to your doctor immediately. The most common side effect of this injection is mild to moderate bone pain.
I'm ready to start.
I'm ready to fight.
I'm ready, thanks to Neulasta.
Ask your doctor about Neulasta and how you can be ready for chemotherapy.
I'm ready to fight my...
Now you might ask why I picked of all the commercials this one, because this one was a very strategic ad. Because what you need to know is at the same time that they were telling patients to ask their doctor, they were doing something else. They were priming the doctor to get ready for the question. What they were doing was offering physicians a financial inducement. They called it a rebate. That for every dose of Neulasta, Neupogen, or Aranesp that you used, you would get money back. This all started concurrently. They're telling the doctors, we got this new program. You prescribe it, you buy the drug from us, we'll send you back $100, $150, whatever it was. And then they're advertising, telling the patients, ask your doctor if you need this. So now the doctor's got an incentive to give it. The patient has an incentive to ask. Now, I would ask, when you buy a car and they advertise a rebate, who gets the rebate? You, right? They tell you, if you buy my car, I'll give you $1,000 back. But if they're giving the rebate to the physician for prescribing the drug, my question is, why isn't that called a kickback? And it is a kickback. Because the doctor wasn't saying to the patient, oh, by the way, when you get your bill and it says that you owe us, $4,000 for Neulasta, bring it in and I'll give you $100 back because the pharmaceutical company is giving me money. Okay, so this was well timed. They didn't get away with it for too long. And under pressure from Congress, Amgen had to back down and put an end to its most controversial drug pricing practice for cancer patients. They had to end their practice of offering, quote, rebates to oncology clinics for their red cell and white cell colony stimulating factors. They had provided over $800 million in 1 year alone to various cancer clinics. I know as a fact, I know doctors, because I'm still friends with doctors in private practice, who said that during those years that they were doing this, they were increasing their income by over $150,000 a year, more than they were making seeing patients by just prescribing drugs. So how often was a doctor going to say, well, with your 5-FU, you don't really need Neulasta. It's not that myelosuppressive. You don't need it. The patient says, I'm supposed to start chemo. I want to be ready. So should I get this drug? And the doctor says, sure. So the unknowing accomplice in this scheme was the patient, the poor patient who just wanted to be ready. And notice, we're going to show another slide later about how they kind of give you false impressions. Do you remember she's driving and she's laughing as her kid's letting balloons out the window? Not too many people were laughing on the way to go get chemotherapy. It's a very serious topic for them. But they show everything's going to be happy and cheery and these emotional appeals. So how did we get here? What's the oversight of medications? Well, the Food and Drug Administration is responsible for advertisements for prescription drugs. And their focus is on making sure there's a fair balance of risk and benefit, not of statistical significance of the drug or clinical significance. So you can power your study with enough patients to show a one-day survival in 1% of the patients, and the FDA will approve the drug. And then because of this new provision in advertising, they can just say this drug provides longer survival, which technically is true. The FDA does not look at that. That is not in their scope. So they don't look at cost effectiveness. Now, for health care services, like when you advertise your clinic, or MD Anderson says, come to us, or Cancer Centers of America, they're not under FDA. They're under the Federal Trade Commission. And the Federal Trade Commission has this dual purpose to protect consumers and promote competition. Okay? So for advertisements for health care services are treated no differently than advertisements for consumer goods. So Best Buy can say, come see us. We have the best value in TVs, and we have the best TVs. They don't have to prove it. Nobody's going to come and say, no, you sell the same TVs that everybody else says, and your TV is no better, and your price is no better. They can say whatever they want. The Federal Trade Commission doesn't interfere with what you say. So if you want to say, we have the best results with cancer patients, and put it on a billboard out on Highway 49, you can say that. Nobody, so you can see that the FDA only deals with drugs and says as long as you proved your significance, you can say whatever you want about it being better. And then the Federal Trade Commission says it's like Kroger's advertising that they're better than Brookshire's. You can say whatever you want. So you've got these dueling oversight regulations. You got the FDA versus the Federal Trade Commission, and lots of things fall between them. Now here's an example. This is an advertisement that was in a magazine. I have taken out the clinic name. It was in Texas, and I've decided to do that because I one time gave a talk and mentioned something, and one of the students came up and said, that's my dad's business. So we won't do any blame and shame stuff. But this was for an MRI-guided focal laser ablation. And they showed you all the problems, the morbidity, and all the problems with prostatectomy versus radiation. Lots of problems. And then they say, let's look at our new MRI-guided laser ablation. No radiation, no surgery, no needles. And they got the guy running to the finish line, and it says here, treat your prostate cancer means a new lease on life. This is okay by FDA, doesn't even look at it, and the Federal Trade Commission says nothing wrong with it. But let's look at the ad. When you go back and look at the studies that they had to publish, you'll find that they said the following. They said, and these are quotes, patients were extensively consulted regarding the very limited short-term and lack of long-term outcome data with focal prostate cancer laser ablation. So you're taking people who have potentially curable prostate cancer, and when they were signing up for the study, you had to say, there's very limited data. We know that I can make your tumor look smaller today. I don't know if it's going to last till tomorrow. And would that guy be running towards a therapy which advertised very limited outcomes data? Probably not. And they say no needles. Well, Valium was administered prior to the lidocaine periprostatic nerve block. I don't know how you do a nerve block without a needle. And then they had to use a 14 gauge, which isn't small, a 14 gauge cooling guide with an MR compatible trocars placed into the target lesion. That sounds like a needle. And then this assumption-laden decision-making. They have you assume that you're going to have a new lease on life. This is legal. This is absolutely fine. Even though if you look at the original data, it's nonsense. So how is cancer care advertised? Some of you came to our ethics conference a couple years ago, and Robert Arnold was our guest speaker. He's one of my inspirations, and he is one of the people who looked into this. And what they looked at was various things that were mentioned. And it's not surprising, maybe it is, that it's not 100%, but only about 60% even mention the cancer type when they give an ad about cancer. The stage, only 9%. So a drug may be indicated for a certain stage disease, stage 1, but they don't tell you that, so patients who have widely advanced disease want the same drug. They oftentimes, a third of the time, mention the benefit, but notice they don't quantitate it. Only 2% of the time do they quantitate it. So you don't know what you're buying. I'm telling you, I got something in my back pocket. I'll sell it to you, Dr. Todd, for $1,000. Do you want to buy it? You're likely to say, well, what do you have? If it's a 2-carat diamond ring that I'm selling for $1,000, you'd probably say that's a good deal. If it's a broken pencil, you'd say, I don't think so. Okay? So they don't tell you in the commercial the benefit. They don't mention risk rarely. Rarely do they mention risk, and in 0% of the time do they quantify it. So they might say you might get a rash, but they don't tell you how often. Cost or coverage, only 5% of the time is that covered. Now why is this important? How do you all define, we're going to talk about this a little bit later, but this is a good time to talk about it now. How do you define quality or quality of care or value? What's value if you had to make it into a mathematical equation? It's benefit divided by cost, right? If it gives you a lot of benefit and little cost, it's a lot of value. If it's little benefit and a big cost, it's little value. So here, patients don't know the benefit, and they don't know the cost. So how are they supposed to determine if it's valuable to them? So while providing limited essential information about risks, benefits, indications, or costs, clinical advertising depended much more on emotional appeals. And here's some of the ones that in this Arnold paper they talked about. And if you watch TV, they're almost always going to use one of these things. Either evoke hope for survival, Call us today and begin your journey from cancer patient to cancer survivor. Your best chance of beating cancer. 61% of the ads had something about you'll survive better if you use our drug or come see me. Fighting language, winning the war against cancer. We help you fight to win, or American Cancer, or the Cancer Centers of America. We know how to fight it. 41%. Individualized care. Now we have all this targeted therapy, so every commercial talks about genomics. No two patients are the same, neither are their tumors. Molecular profiling provides most personalized and precise treatment. I would say personalized therapy would mean sitting down with the patient and talking about what are your goals and what can these drugs achieve, not what's the target. Evoking fear of death, loss, and disability. When I heard the word cancer, I immediately worried about who would take care of my family. So they're telling you, if you were diagnosed with cancer, you got to worry about who's going to take care of your family. Time is of the essence. Call for an appointment now. You don't have time to think about this. Unrelenting care. Care that never quits, and we won't let you give up. This very much disappoints me, this last one, because one of my favorite fellows who graduated several years ago here is in one of the hospitals here. I'm not going to mention his name or the hospital, but you've seen his ads. And he's the last, they do all of their people on TV, the nurses and the doctors, and he's the last one because he's now the director of their cancer center. And he says, we won't let you give up. Well, what a crock of shit. And excuse my language, what do you mean we won't let you give up? You know, I may choose, if you tell me that all you can do is provide me an extra 2 weeks of survival, and it's going to cost me $200,000, I might decide, no, I've got a daughter in Israel I want to go see, and I want to leave my wife in a house, not, you know, where we had to mortgage it to pay for just to get a few extra days. Don't tell me you're not going to let me quit. So that is very offensive to me. Shared decision making, which is what you would like to see, was only 6% of the time. When they say they let me know what I was up against and help me decide what treatment would suit my needs. It's only 6% of the time is that part of their advertising that we'll sit down with you and help determine what's right for you. Now, President Nixon declared war on cancer in 1971, and now we have our moonshot. And we use a battle metaphor often. And these metaphors are not alone by President Nixon and cancer centers. The media has embraced the metaphor. So you see on TV all the time, don't you, that so-and-so just lost his battle with cancer, or she lost her battle with cancer. Right? They don't say died of cancer. You lost your battle. So it's a battle metaphor. And why do they want a battle metaphor? Well, like most battles, if you fight hard enough and long enough, the battle potentially can be won. It doesn't mean you're going to win each time, but if you fight hard enough and you don't give up and we don't let you give up, you might just win, which leads to an unintended consequence. The patient becomes a loser even when the battle could not be won. Like the majority of patients who have widely metastatic carcinoma. If you have widely metastatic colorectal cancer in your liver and lungs and bones and brain, you're not going to be cured. And you can fight all you want, you're not going to be cured. But then when you die, you've got your family going, Dad, you know, you got to eat, come on, you know, you got to lick this. You were able to take on, you know, the Viet Cong when you were in the Vietnam War. You're a fighter, Dad, come on, you got to do this. And so the patient dies with his last breath being an act of failure. So the patient who adopts the battle cry, I'm going to beat this, and we all see it. Patients who say, I'm going to beat this, they're more likely to fight to the end. Now that's a problem when you get into the ethics of even the cost of healthcare. These are patients, it's very clear they want more chemotherapy at the end of life. These are the people who are getting chemotherapy within a week of their death. And the doctor knew they're likely to be dead in a week, but they're still giving them chemo because the patient wants something. They have more visits to the emergency room, they have more intubations and failed resuscitations, are more likely to die in the intensive care unit. They're less likely to consider palliative care and hospice care. Why would I? That sounds like you're sending me home to die. I want to fight. I need to find a doctor who's not going to let me give up. Now, when's the last time you heard he lost his battle with ischemic cerebrovascular disease? Or she lost her battle with ischemic coronary artery disease? We don't use a battle metaphor there. There, all we say is he died of a stroke and she died of a heart attack. But with cancer, it's the battle metaphor. It's always. So next time some celebrity dies and they're talking about it on the news, I guarantee you they're going to say lost their battle with cancer. So when emotions are preyed upon, the media lends a helping hand. And media plus superlatives equals hype. So again, they are the unwitting assistants of big pharma. Whenever I go to the ASCO meetings and they talk about some study that showed some benefit in a cell culture model, I get back to Shreveport and I got 20 patients calling me saying, shouldn't I be on that new drug? I saw in the newspaper that a new breakthrough drug for cancer is being developed. Or it's a game changer. These are the words that the media uses. They go to all these medical meetings and then they hear about something that was maybe not even a phase 1 trial. It's something that people are saying we should do a phase 1 study because it worked in mice. But the media says they want to sell articles. People are going to read if it says life-saving, breakthrough, revolutionary, whatever. So let's look at, this was in 2015. There were 94 articles reviewed that used 97 superlatives referring to 36 different drugs. Now what you should know is half of those drugs were not FDA approved. And 5 of them, they were using superlatives in the absence of any clinical data based on mouse cell culture or preclinical work. No data at all. But the newspaper and the radio and TV is talking about doctors at the cancer meetings in Chicago just learned about this new breakthrough drug for melanoma. And every patient who's been in hospice for melanoma signs out and comes to the office saying, I want to get that new drug. And again, the reason I'm telling you these things is we're going to be making a decision about the ethics of this. Is that something ethical to take somebody who's got one path that they've thought through carefully with their physician, but now because the media takes something mentioned at ASCO and calls it a wonder drug, you got patients signing out of hospice wanting treatment. The superlative was credited, it wasn't mostly physicians, only 27% were physicians, industry experts, 9% patients, 8%, and a Congress member, I don't know what he had to say about it, was 1%. But 55% of the superlatives were used by the journalist alone. So the journalist now can go sit outside or read the ASCO reports and take something that looked interesting, worthy of study, and go home and print in their newspaper that it's a wonder drug. So I like this. Now, here's an example. In 2008, a practice-changing study, it was called in the media practice-changing study, was introduced at the ASCO meetings. It was one of the plenary sessions. And it was heralded as a new standard first-line treatment for specific patients with advanced, incurable lung cancer. And here's what they found, is that it changed their survival. The average survival was less than 5 weeks. It was 4.8 weeks. 11.3 months versus 10.1 months. But it was powered enough that they could show a difference. Well, how much did that average of 5 weeks cost you? This new standard first-line treatment increased the average survival by 5 weeks at a cost of $80,000. But it wasn't $80,000 just for that 5 weeks. You have to start the treatment on day 1. So you're getting the whole 11 months, you're getting it. And it's a monoclonal antibody, cetuximab, which is very expensive. 26% increase in neutropenic fever, so patients spent time in the hospital. All it gave them was an additional 5 weeks on an average. Well, it may be We have to decide, walk the tightrope. Is 5 weeks worth $80,000? Maybe if it's my dad, it is. Maybe if it's your dad, it isn't. I don't know, but how do we make a decision? But here's one way we might look at it, is if we agree that this should be adopted as a new standard of care, we would need $44 billion to extend the lives of 550,000 Americans die of cancer every year. So if we said that all 550,000, you're still going to die, but I got this new drug that the course of therapy is $80,000, and instead of dying in the middle of August, you can die in late September. You get an extra 5 weeks. That's going to be $44 billion, and not one of those patients would be cured. Now, $44 billion, what's $44 billion among friends? Well, the NCI budget is $4.95 billion. So it's almost 10 times the budget of the NCI. We wouldn't have cured anybody. They would have gotten an extra 4.8 weeks of life, and we would literally bankrupt healthcare. But despite this, everything in the paper, in the newspapers and on TV was that it's a practice-changing study. And I'm not exaggerating. We got home and patients were calling saying, is it too late for me to start on that drug? Because they watching TV. So of the therapies approved for solid tumors between 2002 and 2014, the median gains in progression, these are small little incremental benefits, 2.5 and 2.1 months for progression-free survival and overall survival. And yet, many of these therapies cost $10,000 to $30,000 per month, not just per month of benefit. How many of you have GoodRx on your phone? Okay, I want you to look up Revlimid. It's a drug we use for myeloma. It's an oral drug. Take it at home. How much does it cost? Revlimid, R-E-V-L-I-M-I-D. By the way, the number he's going to tell us is only if you have a coupon. Who said it? $15,000 for 28 capsules. A month's supply of an oral medication is $15,000. Doesn't cure myeloma. It adds a little bit of time to your life. $15,000 a month. Now, if you pay a copay, how many people can afford that? How many people are going to have to mortgage their house? You know the number one reason for bankruptcy in the United States is unexpected health care costs. But if you ask most doctors, if you ever put a patient into bankruptcy, they'll say no, because they don't know. After the patient dies, I don't know what happens to the widow or the widower. Do they have to sell the house? Do they have to cash in the kids' college funds to pay for the care that I gave them so that they could live 5 extra weeks? Now, if I had that discussion with them and they chose 5 extra weeks is worth this money, then God bless them, they should get it. But most of us don't want to have that discussion because we kind of feel like we're prostitutes if we bring up dollars. Most doctors would say, oh, I'm not supposed to talk about the cost of a drug with the patient. Well, yeah, you are. Financial toxicity is every much as real as physical toxicity. As a matter of fact, a little nausea I can deal with. Going into bankruptcy, I don't know that I could deal with that. So I kind of want you to tell me about what it's going to cost. So won't patients be able to decide if the cost is justified by the benefit? Shouldn't they be able to tell? Well, as we already said, value is benefit over cost. And in Dr. Arnold's paper, they showed that rarely do patients know what the benefit is. And I can tell you, doctors don't routinely say it. And nobody talks about the cost. So how can they do a value calculation? They can't. So that's why they depend on emotional appeals. And this was in the New England Journal, and I think that's one of our better throwaway journals, isn't it? And it was at Dana-Farber Hospital, good hospital. Patients who had advanced incurable metastatic cancer, 69% of those with widespread lung cancer and 81% of those with widespread colorectal cancer had an inaccurate belief that the chemotherapy was going to cure them. Now, how did that happen? The doctors, it's very interesting, the doctors would say, they pass a lie detector test. I told the patient it was incurable. The patients will pass a lie detector test saying, the doctor never told me that. How can that be? How can both statements be true? Well, it's because the doctor is talking in doctor language. The doctor knows that metastatic colorectal cancer is not curable. The doctor, when he uses the word palliative chemotherapy, knows that that means it might add a little bit of time. But do you think your average patient knows that? You might assume that if you've said metastatic, that it's in your liver and lungs, that they would know. Well, they might have had a brother who had testicular cancer when he was 24 years old, who had disease in his liver and lungs and was cured. Or they may have a cousin who had Hodgkin's disease and was all throughout her body and her bone marrow that was cured. So just because we know that metastatic colon cancer is incurable, just by telling the patient you have metastatic colon cancer and we're going to start palliative chemotherapy does not mean you've had a discussion about the goal of therapy. And this study demonstrates that. The majority of patients taking treatment think that they're being cured, and that's why we get so many angry, when you guys are on the wards, you get some angry patients, don't you? Because they say, I thought this treatment was going to cure me. So there's other problems in decision making. Do you think your patient would be more interested in a treatment that will cut the risk of recurrence by 50% or a treatment associated with a 0.1% absolute reduction in risk of recurrence? Well, we know what the answer is, 50%. Well, a reduction of, if you said without the treatment, 2 out of 1,000 people are going to relapse and die, but with the treatment, 1 out of 1,000 will relapse and die, that is a 50% reduction, isn't it? Half the number of people died. But that also represents, since all you saved is 1 out of 1,000, that also represents a 0.1% absolute reduction in risk of recurrence. Both statements are true, but which sounds better? When the doctor says, this will cut your risk of recurrence by 50%, or this is going to cut your risk of recurrence by 0.1%. Now, even if they said relative risk and absolute risk, most patients won't understand that because we have what we call statistical illiteracy. And doctors take advantage of that because we don't want to tell the patient that there's no hope. So I'm not going to tell the patient, it says, 1 out of 1,000 people I'll save, I'll say I'll cut your risk of dying of this disease by 50%. I'm not lying, but I'm certainly depending that the patient is illiterate with statistics. So many of the consequences of direct-to-consumer advertising are intentional. They want to increase, pharma wants to increase the market share, and they want the consumer to use more. But some are not, and those are the unintended consequences. Those who can travel from place to place looking for the best care may delay starting treatment, and I've had patients who've done that. They have a curable disease if they get started now. But they go, well, I want to go to MD Anderson. And then they say, I went there and I got an opinion, but I've heard about Cancer Centers of America. I need to go there. I got an appointment next week. And then I want to go to the Seidman Cancer Center. And I want to go to Memorial Sloan Kettering. And they can't make a decision. By the time they finally decide, now their disease that was stage 1 is now stage 2 or 3, and they've lost their option. And we call that analysis paralysis. Those without the resources for travel, like many of our patients, feel that they're getting second-rate therapy. I wished I had the money to go to Cancer Centers of America or to MD Anderson because I'm watching all the ads. They cure their patients. I'm stuck here at LSU. Well, they don't know they're going to get the same drug. Cisplatin is the same whether they give it in Texas or they give it in Louisiana. And those who do not achieve the desired outcome may feel that they did not try hard enough. So patients die feeling like they failed. And you'll notice this was just, 5 days ago, August 11th, when I was preparing for this talk, I found this. While dealing with lung cancer, my friend seized in her blog at pharmaceutical advertisements and hospital commercials that bombard us daily with pictures of joyous cancer patients supported by doting intimates. And you've seen that Opdivo commercial for the patient who has failed every line of therapy for non-small cell lung cancer. It's a monoclonal antibody, and they flash on the building with laser, improved survival, and they have the guy, the old man, out playing softball with his grandson, hitting the ball and running the bases. Like, that's what you can look forward to. I can tell you every patient that is eligible for Opdivo is pretty much bedbound by the time they're getting it. They're not playing softball with their kids. And that's what they're referring to here. They always show, and even that other commercial I showed the happy lady driving and the kid playing with balloons, and everything's all happy. Now this is really interesting.
Lynn Redgrave from Bristol Myers Squibb.
I want to die, or from exhaustion dancing the tango. I want to die of laughter on my 87th birthday. But I refuse to die from breast cancer. I want to die from something else.
Your will, our medicines. Together we can fight the serious diseases. Bristol Myers Squibb. Together we can prevail.
So what's the message? The message is that if you don't want to die of cancer, just be sure your doctor knows that. So when your doctor says this is incurable, just say, oh, doctor, you must have me confused with somebody else, because remember, I'm the one who refuses to die of breast cancer. So how could such an inspirational and encouraging ad be anything but good, right? This should be good. It's encouraging people to fight. Well, here's a letter that somebody wrote. Your ad suggests hell out and out states that she survived because she refused to die, which is to say that surviving breast cancer is a matter of moral fortitude. If you want it enough, you'll live through the breast cancer. Ipso facto, those who die because they're weak, because they didn't fight hard enough. So now if your mom died of breast cancer, you just say, well, my mom gave up. Your ad is deeply offensive to anyone who's lost someone to breast cancer. My mom didn't die because she was weak. My mom didn't die because she failed to take care of herself. She found the cancer early. She treated it aggressively. She did everything she could to live. She died anyway. She died because she had the horrible bad luck to have a form of disease that was very difficult to treat. So that is a price you pay when you do this kind of advertising. Because you don't know about the other people who had buried their moms of breast cancer are now wondering, gee, maybe I should have encouraged mom. Maybe I was wrong to encourage mom to go into hospice when her doctor recommended. Maybe I should have encouraged mom to fight harder. Now guess what? 4 years later, Lynn Redgrave died. And guess what she died of? Breast cancer. Do you think Bristol Myers Squibb came on television and had a new ad showing that and said, oh, by the way, 4 years later she died of breast cancer? They didn't do that. So should we advertise directly to consumers? Something that whenever I give a talk on ethics, I always go to my original ethics books, Principia Ethica. G. Moore observes that it appears to me that in ethics, as in all other philosophical studies, disagreements are mainly due to a very simple cause: the attempt to answer questions without first discovering precisely what question it is you want to answer. So when you have to answer the question, is direct-to-consumer advertising good or acceptable, you have to define your question. Is it legal? Well, what does the law say? The law says, yeah, it's legal. Is it ethical? And to answer that, you have to get into the 4 basic principles of ethics: beneficence, non-maleficence, justice, autonomy. Who does it benefit and who might be harmed? Well, who does it benefit? Is the purpose of direct-to-consumer advertising really to educate the public or to increase market shares and profits? I think we know the answer to that. And who might be harmed? In my talk, have I shown you that people can have emotional trauma, that there can be financial or physical harm when patients buy into this nonsense? I think at least I hope I've shown you that. The problem is regulatory agencies such as the FDA and the Federal Trade Commission only address the legal aspects. The ethical aspects are left to you. You have the right, when you go into practice, you can put signs all over Highway 49, and you can advertise on TV. You can do whatever you want. And you can go to every dinner that a pharmaceutical company invites you to, where they're going to, at Superior Steakhouse, where you get a free $50 steak for listening to somebody sell you a drug. You can decide to do that. I choose not to. So Kathy Kuvion knows that if any pharmaceutical company wants to come and talk to me, I don't meet with them. I don't talk to them. If I can't learn it from a medical journal, then I'm not meant to know that information. I don't need to hear it from a drug rep. But that's me. You have to decide yourself. So we're now going full circle with historical perspective. In 1847, the Code of Ethics of AMA, as we said, they banned it. But in 1980, it was overturned. Now, this is interesting. In November of 2015, I don't think this will go through because we live in an age of Citizens United where the government has already decided they don't want to get involved in business decisions. But at least the AMA, I think, did the right thing. They adopted a policy calling for a ban on all direct-to-consumer advertising of prescription drugs and medical devices. And Patrice Harris, who is the board chair, said today's vote in support of an advertising ban reflects concern among physicians about the negative impact of commercially driven promotions and the role that marketing costs play in fueling escalating drug prices. Keep in mind, the main reason everybody wants to blame Obamacare or the Affordable Care Act, why are insurance prices going up? Well, every time a new monoclonal antibody comes out or a new Revlimid comes out, the insurance companies have to take into account that a certain number of people are going to now need that drug. And so it's pooled risk. Everybody's premium goes up. You can't every year have all these new drugs come out, these new monoclonal antibodies that are going to cost $30,000 a month and not expect the insurance companies to raise your insurance premium. Now, of course, Big Pharma, they see it very differently. They say, no, 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 no. This makes patients more aware of conditions that they have which may not have been diagnosed before. It encourages them to see their doctor for important doctor-patient conversations. They do not. They do not. That's not why they're doing it. If they want to do that, take out a public service announcement. You know, you can do a public service, say this is what melanoma looks like, this is what a normal mole looks like, this is what melanoma looks like. But you don't have to link it to improved survival with melanoma. So conclusions, with serious illness, like the ones I take care of a lot of, direct-to-consumer advertising can be associated with the statistical sleight of hand, and that's because of statistical illiteracy, intentional or unintentional. Decision-making that we hope, at least the pharmaceutical company hopes, will be hijacked by emotion. I'm going to let my amygdala decide if I want to spend that money. Assumption-laden decision-making, analysis paralysis, adoption of the fight to the death warrior myth, so everybody has to die in the intensive care unit, and more aggressive care at the end of life, and all of those things cause healthcare to be more expensive. And with less serious illnesses, it's still, now you got disease branding. You got every woman coming to her doctor saying, do I need Serafim for, I think I get a little moody during my periods, and by the way, do I have an odor doctor? Shuffling the priorities of a healthcare encounter. How many of you have had something you need to talk about with the patient, a test result, but they want to talk to you about the ad they saw on TV? Again, the assumption-laden decision-making, sleight of hand with statistics, and more ordering of unnecessary studies. The patient saying, shouldn't I have a PET scan? Because I saw that if you go to MD Anderson, they evaluate everybody with PET scan. Okay, we'll order a PET scan, even though you don't need one. And that causes more expensive health care. So perhaps the best advertising should be word of mouth. I have the best doctor, I go to the best clinic. Maybe that should be the best. Any questions? I apologize for me being passionate about this, but this really burns me because when I'm trying to have an end-of-life conversation with somebody, but they're refusing to give up because they saw some commercial, that really bothers me. Questions? Okay, well, thank you.